Hello, it's Beth Wright. I'm providing you a podcast for Chapter 20. This is NUR 237, Unit 3. And we're going to be talking about the drugs used for tuberculosis and the Mycobacterium avium complex disease. So these are your exemplars. Of course, the drug class for tuberculosis or TB, the isoniazid or INH, and I'll refer to that as INH, the rifampin, the rifampicin, the rifampicin, the parazenamide, and the ethambutol. These are your drugs that are in the first class of treatment for tuberculosis or for the Mycobacterium avium complex disease. So let's first talk a little bit about tuberculosis. It is an infectious disease, and it usually does affect the lungs, but it can be anywhere. It can be in the kidneys and the joints. It can be anywhere in the body, but we primarily see it in the liver, not the livers. So the organism is referred to as the Mycobacterium tuberculosis, or the bacillus is another way that you'll see that organism. And it's one of those organisms that's very smart. It can resist the phagocytosis and it can develop drug resistance. So the other thing is it can lie dormant in the body, and we're going to talk about that, how that all takes place in just a second. Now the MAC, or the Mycobacterium avium complex, this is where there's a couple of organisms, the Mycobacterium avium and the Mycobacterium intracellular. And these are two different organisms. They very closely resemble the Mycobacterium. So they've grouped them together as the Mycobacterium avium complex. And so you'll see that MAC, those initials there for individuals. And this is where it's not a very common thing. Except for individuals who are very immunocompromised. So we're going to see this kind of illness, and if you'll think back when you studied about HIV and AIDS, you might remember this as one of the types of pneumonias that individuals get. And so this is what this is talking about. And of course, when somebody's immunocompromised, they can pick up, the strangest types of bacteria, fungal infections, bacteria, viruses, they will pick up anything and everything. And this MAC is one of those that we're talking about. It can come from, one source that I was reading about, it can come from hot tubs, hot water systems, bathrooms, house dust, soil, birds, farm animals, even cigarette components can contain this. And for the healthy person, it's not going to affect us at all. But for that immunocompromised person, they can definitely get impacted, and they, can pick up this kind of thing. So we got to think about your immunocompromised patients. Who are we talking about here? HIV patients, your cancer patients that are taking radiation or chemotherapy, diabetics it talks about in your book, organ transplant patients. So, anybody that's on long-term corticosteroids. So your immune system, when it gets damaged, it can, it really can cause a number as far as picking up weird, different diseases and illnesses and stuff. Just like HIV patients, drug resistance is a major concern with that illness as well, because that virus is so smart, and it can, learn and about the drug and be able to, have drug resistance, and that can happen with these medicines as well. So tuberculosis is commonly occurs in many parts of the world. The third world countries are pretty much, affected more than we are. In the United States, we are at a low level. Um, However, we do have newer cases developing in foreign-born immigrants, and there is a large number of inactive latent infections of TB, and we'll talk in a minute about what we're meaning when we say inactive latent. Contributing factors, there's increased exposure during the disease resurgence in 1985 to 1992. And immigration from the countries where the disease is common was on the rise, or maybe still is on the rise. And of course, we have individuals who are increasingly immunosuppressed for different disease processes that we've talked about already. Now, the 4 phases of tuberculosis, the way it happens is first it's this transmission, and that's where an uninfected person receives the bacteria via airborne from an infected person. And then we have a primary infection, and it takes about 2 to 10 weeks after exposure for the infection to occur. And then within approximately 6 months of exposure, the macrophages encapsulate the bacilla organism into a tubercle, calcified tubercle. And so that's one reason why they say do a chest x-ray, because they can pick up on that calcified, encapsulated bacilla in the lungs. The macrophages are unable to eliminate the bacteria completely when it is encapsulated like there, okay? And so that's what makes it the latent. So the latent, when we say latent or inactive, the bacteria becomes inactive, but it remains alive in the body, and it can become active later in life. People with inactive or latent TB infections have no symptoms at all. They don't feel sick. They can't spread it to others. But they can become active if the immune system is compromised, or they may never come active. So what kind of people are latent people? So this is when a person may test positive with their TB test, but they don't have any signs or symptoms of TB, any active signs or symptoms of TB. And so sometimes we see that with individuals, and they recommend that these folks go through a series of testing to make sure they in fact have been exposed. There's some additional tests that can be done, and because again, it's just like any illness, individuals are susceptible to exposure to anything unless you live in a bubble, right? So it's likewise with TB. People can be exposed to it and not even know it. So it's important that when somebody is tested positive, but they don't have those signs and symptoms, that they do have follow-up care to make sure that they don't become active. That's the key there. And then, of course, active tuberculosis is when somebody with latent TB develops an active disease in 2 ways. Either further exposure to the infected airborne droplets, or they have a reactivation of the latent TB because of the immune system being weak. So this is a diagram that just kind of shows you, someone's exposed to TB, and 70 to 90% of the time, people will not become infected, and it will lie dormant there. 90% of the time, the dormant will never develop TB, and they're not infectious. If 10 to 30% of the time, people will become infected and become have active TB. But again, a small percentage there. 5% within 2 years and 5% within years after exposure. Now, if it goes untreated, 50% of those patients with active TB will die within 2 years. If it's treated effectively, they can be cured. So I put you a pictogram here of tuberculosis, and these are our clinical manifestations like progressive fatigue, malaise, feeling really tired all the time, not feeling good at all, anorexia, weight loss, a chronic cough, typically productive. Night sweats is a classic sign. The hemoptysis, which is blood in the sputum, that's also a classic sign, but in the advanced stage. They may have pleuritic chest pain and a low-grade fever. And so our diagnosis here is the TB skin test, chest x-ray, and then they're going to have sputum studies. Got to collect 3 different sputums on different days, and then they're sent off and they're checked for that bacillus organism. And so the treatment there is the first line treatment is your exemplars that you have, and the medications can be for 6 months or longer. You can have decreased activity, respiratory isolation until negative sputum, and frequent outpatient treatment. Now, when we talk about the respiratory isolation, this is where your patients must go into, if they're in the hospital setting, they need to be in a negative air pressure room, okay? And that has to do with the air being circulated to the outside and not within the hospital setting. And there's so many exchanges of air with those negative air rooms, and our local hospitals most hospitals have those rooms. So it's real important that these folks go into those negative air rooms. That's essential. Now, drug resistance tuberculosis definitely can happen, and it's a major concern. It's a concern with your latent TB cases, and also an increase in drug resistant infections, because again, those organisms are smart, and they mutate in order to not have the drugs to work on them. And so it's really crazy, the whole microbiology part of organisms and how smart they are against our antibiotic treatment, or for this case anti-tuberculosis treatment. Its resistance is attributed to poor compliance. So a lot of these patients, goodness, there's typically it's not just one medicine that you take. There's a regimen of 2 and 3, maybe even 4 medicines, and of course, the more medicines people have to take and the longer they have to take them, the poor patient compliance can be a part of that. Of course, new strains are developed with patients who are immunocompromised, and then those new strains are transmitted to individuals, okay? So we can have the multi-drug resistance tuberculosis, which are resistant to the first-line treatment. They have to go to the second-line treatment, which includes some heavy-duty antibiotics. And then the multi-drug resistant tuberculosis can then become the extensively drug resistant tuberculosis, and that's when these drugs are resistant to second line medications. and there's no effective treatment. So major concern here with anybody who's HIV positive or immunocompromised for sure. Again, factors contributing to the extensively drug-resistant TB, a delayed diagnosis of the TB, and then delayed determination of whether the medication is working. That may take several weeks because it may take a couple of weeks for the bacillus to be affected, and then you have to do the sputums, and it takes a while to get all of that back. So it takes several weeks to determine if we're on the right track with the medications. Now, the CDC and the ATS is the American Thoracic Society, and the IDSA is the Infectious Disease Society of America. So they have worked to improve the treatment of TB and to efforts expanded to treat the latent TB, as well as improve the control over specific populations. So children and adolescents and foreign-born persons and are HIV positive, homeless persons, and specific facility residents such as in prisons, crowded areas. These are areas where you're going to see TB the most. So nurses' role in helping with this is to, of course, follow recommendations to prevent transmission, performing and reading the TB test. That's in your book for sure. You want to look at that on page 351, box 20-1. Managing TB clinics may be a nurse's role, and typically your public health departments are the ones that will do this. Tracking contacts of those with active disease so that we can make sure those contacts are not going to be the latent TB type, and assessing any kind of risk factors there. And of course, teaching all the time. Teaching, we're going to do teaching about everything. Administering TB medications, and it talks about the DOT, the daily observation of therapy, meaning that literally a nurse will go and the patient will take the medicine in front of them, so we can be sure that there is compliance going on. They're going to monitor, nurses' role also, the development of the multi-drug resistant and the extensively drug resistant TB, and watch for that. Going to assess for that, and the way that's done is you watch for those signs and symptoms. Are they still present, or are they being alleviated? And so definitely being proactive with that kind of thing. Again, the drug resistance may not be suspected until 2+ months after drug therapy, and that's a long time. Delays in identification of treatment, of course, allows for additional transmission of tuberculosis. So things that are needed is better international standardized tests to check for these for TB, new anti-TB medications, drug therapy, and better diagnostics for TB. So let's talk about our medicines here. We have our primary first-line medications, and that is your ones that are used to treat the latent, the active, and the drug-resistant TB infection when possible. So, patients with TB or latent TB cannot spread to others, but the treatment of latent disease prevents progression of the disease to an active state. So The line of thinking there is to treat an exposure. Um, First line anti-TB drugs are your ones with the exemplars, the INH, the rifampin, and other rifampicillins, and then the ethambutol and the pyrazimide. Okay, so let's the second line of treatment are those aminoglycoside antibiotics, certain fluoroquinolones, and other medications, heavy-duty ones for sure. Okay, let's talk about INH first. It is a bactericidal. There's a black box warning with it. It can cause drug-induced hepatitis. So what does that mean? What do we got to assess before we give this? We got to know our contraindications, and we got to, assess for that black box warning. If there's a possibility of liver-induced hepatitis, we got to be sure the patient doesn't have some kind of liver impairment, liver problem before we start that medication. Contraindications are allergies and liver impaired, and caution is warranted in the elderly patient as well as those with chronic non-INH related liver disease or chronic alcoholism. Also, those who are taking seizures, especially if they're taking the phenytoin, and those with severe renal impairment. So we got to assess that medical history and medications. We got to assess the labs. We got to assess the person. Are we having jaundice? Are we having, abdominal ascites? Are we having signs and symptoms of liver impairment or renal impairment for that matter? Adverse effects. Also, we got to assess the alcohol use in the patient as well. Adverse effects is going to be the liver issues as well as peripheral neuropathy. So what are signs and symptoms of that we need to be watching for on our patient? For our nursing interventions, we're going to, of course, assess the patient. For administration, we can give IM injections with this, but only if the patient can't tolerate the PO amount. The PO should be taken on an empty stomach, but it can be taken with food if they have, stomach upset. It's also recommended to take this with vitamin B6 to help prevent that peripheral neuropathy. Of course, we're going to evaluate for therapeutic effectiveness. So how is that done? Are the night sweats decreasing? Is low-grade fever going away? Is the fatigue better? How's their cough? Is it less productive? Is it decreasing? Are we having less sputum with blood in it, hemoptysis? So checking that therapeutic effectiveness, and also we will be getting the sputum specimens as well. Now, once you are positive with a TB test, you shouldn't take another TB test, okay? Because you've been, person's been exposed. So we're not going to redo the TB test on individuals who are positive, okay? But they will have chest X-rays. They will have, other tests done, sputum for sure, sputum cultures for the bacillus. And then, of course, we're going to evaluate for adverse effects as well. The rifampin is another drug. It's bactericidal. And the use of this one is not only for treatment, but it's also used for prophylaxis for people who have been exposed to meningitis, and also prophylactic for the MAC, for HIV patients. It's also used for treatment of leprosy, and some unlabeled uses that your book talks about. So just in case if you see this drug, used for somebody, it may not be TB that they have. It may be these things. So unlabeled use is a prosthetic valve for endocarditis due to MRSA, or prophylaxis for Haemophilus influenza infections, and certain other MRSA medication or illnesses. So you may see this drug used other than for TB. So again, our assessment, this one is similar to the INH, but there are a few different types of things that can happen with this. But the adverse effects include the GI upset, skin rashes. It is hepatotoxic, and it can cause acute renal failure. Now, this drug can cause a harmless red-orange discoloration of the urine, tears, sweat, or any other body fluids. So it can stain soft contact lenses permanently. So, of course, we'd need to teach the patient about that, and they would need to, get something in place for that. If they use contacts, they would have to, stop using them while they're on that medicine. Prolonged use may result in bacterial or fungal superinfections, so we may see C. diff associated diarrhea or pseudomembranous colitis with this. Also, the patient can have flu-like symptoms that can occur. We also need to be watching for hypersensitivity reactions such as fever, tachycardia, anorexia, malaise, flushing, itching, and rash. So again, we're going to do the assessments very similar to the INH. With this medicine, as far as our administration of it, it can be given IV or PO. With the teaching, always going to be doing teaching. We have to be sure to teach about the decreased effectiveness of oral contraceptives when on this medicine, so they need to use some type of barrier there. And also, they need to report any kind of issues with their eyes. Uveitis, it can cause uveitis, and the patient may have signs and symptoms of that, which would be sensitivity to light, excessive tearing, and eye pain. So they need to report that to the provider as soon as possible. The rifampicin, is the other drug in this class, and it causes mild GI adverse effects, nausea and vomiting. Another adverse effect with this one is it can increase the uric acid in the blood, so hyperuricemia. And it can, if we have a hyperuricemia, then we can have gout. That's what the uric acid is elevated with gout. And so we have to be watching about that. It also produces that discoloration of the body fluid, so we have to teach about that. Severe adverse effects can include leukopenia, neutropenia, and thrombocytosis. So you know what we got to watch for there. Okay, and then the rifabutin can cause a harmless red-orange discoloration of the body fluids. Again, permanent staining of the contact lens. The adverse effects of it is the GI upset, hepatitis, muscle aches and pains, neutropenia, skin rash, and the uveitis, the inflammation of the eye there, and impaired vision. Okay, then we have the paraxenamide. Okay, so let's talk about that. That one is a bactericidal. Adverse effects of that is gout. So again, you're going to see an increase in that uric acid, and it can cause hepatotoxic. So again, what do we need to assess on the patient here? The ethambutol is the other medicine that's listed here, and that's adverse effects is the optic neuritis, and that can cause a disorder of the optic nerve that decreases visual acuity and ability to differentiate red from green color. So they recommend that the patients have testing before they start this medicine, and if it develops, it's necessary to discontinue that medicine. And again, we're going to assess, we're going to administer, we're going to do the drug checking for any kind of interactions, and teach. I've got interventions down there twice, I guess. I guess I was stuck on interventions, wasn't I? We're going to evaluate those therapeutic effects, and we're going to evaluate for adverse effects as well. Okay, so in general, the adequate drug therapy, patients should feel some better within 2 to 3 weeks, a decreased fever and cough, a weight gain, and improved well-being. Treatment continues at least 6 months or 3 months after cultures become negative. And a sputum culture is usually done, they will usually be negative after the 3 months of treatment. If they're not, if we're positive after 3 months, then we have to question the patient, about taking our medicines. Are they non-compliant? Is there what's going on there? Or do we have a drug-resistant organism going on? So either way, we got to look at the treatment, and that treatment is going to be changed. Again, multiple drugs are needed, and it's the duration of the therapy is going to be dependent on what's going on with the patient. And again, multi-drug resistant TB can occur anywhere, and we want to do our best to try to make sure that doesn't happen. Treatment of MDR requires concurrent administrations of more medications, just what your patient is wanting to hear. And it's going to require longer period of treatment and daily administration, as well as that daily observation of treatment. It's very expensive, and then of course the extensively drug-resistant TB is definitely limited, because we, it's meaning basically that the primary and the secondary line medications aren't working. So our goal of therapy for TB treatment is to cure the latent or active infection and avoid that drug resistant, and minimize transmission to others. So we want to be monitoring for the decrease in the signs and symptoms, and make sure that the patient is being compliant with their medication. Strategies for adherence is to support the person, and if there's any way possible that medications can be given over a shorter period of time, we definitely want to try to find that, because that will make your patient a lot happier. Education definitely has to be done. Provide those support services and resources for individuals, and promote communication and continuity of care. This just talks about that daily observation. So healthcare provider or a other responsible adult will be designated to actually see that direct observation therapy happening, and it is considered mandatory for the multi-drug resistant. Clinical monitoring is indicated for every patient. I mean, gosh, we definitely need follow-up here on these medicines, and for adverse effects as well as therapeutic effects for sure, and regular checking of lab work, such as the liver function test, and also renal for the applicable ones. Baseline labs indicated for all patients to make sure any kind of possible liver disease is happening. If they're HIV or pregnancy, early postpartum, and we need to know about that alcohol use as well. Special populations, it talks about in your book about the HIV patient. To prevent the MAC, they may be on these medicines indefinitely. Children certainly can take these medicines as well, as it talks about as describing in each one of them. Older adults, again, the same type of principle. We usually, older adults have more things, comorbidities or things going on, so there may be an issue there. And renal impairment has to be checked because several of the drugs are eliminated through the kidneys. Hepatic impairment, definitely for all of the drugs. And then home care, as far as that daily observation or direct observation of therapy, we know that how strict that's going to be. Most of the time people are not going to like that, but it definitely needs to be done. Now, also pregnancy with a special population, the INH and the rifampin have had good results with no damage to the fetus reported, so that's going to be beneficial for them. Okay, this concludes your podcast.